I definitely want to thank the support of our two co-sponsors for this webinar today, PrEP in Black America and the Research Working Group of the Federal AIDS Policy Partnership. Thank you so much for collaborating with us on this really important webinar. And here is what the agenda is going to look like. You will hear from these folks in this order, starting with Professor LaRon E. Nelson, followed up by Christopher Hucks-Ortiz, Dr. Cedric Pulliam, and then Abraham Johnson. And we will be expertly moderated by Riko Boone from TAG and John Meade from AVAC, both of whom also are deeply connected to PrEP in Black America, as you might expect, and the Research Working Group, as you also might expect. So without further ado, I am going to stop sharing my slides, and I am going to invite John and Riko to say hello and introduce our first speaker and get us going. Thank you so much.
Good morning and good afternoon, everyone. Thank you, Jim, for those introductory slides. Hello, everyone. My name is John Meade, and I'm Senior Program Manager for Policy at AVAC. And I also serve as the co-chair of the Federal AIDS Policy Partnership Research Working Group. Oh, my own face scared me just now, as you pinned myself. I'm the co-chair of the Federal AIDS Policy Partnership Research Working Group, and I am a founding member of the PrEP in Black America Coalition. And I will be co-moderating this session with the esteemed Riko Boone, and I'll have him introduce himself.
You're too kind. Hello, everyone. My name is Riko Boone. I'm HIV Project Director at Treatment Action Group. I also a founding member of the PrEP in Black America Coalition and co-chair along with John of the Research Working Group. You know, PrEP in Black America Coalition is proud to co-sponsor this webinar because, you know, we formed the coalition to act upon a deep frustration that we all had with the persistently low rates of knowledge and utilization of PrEP in Black communities in the U.S. As we see from recent CDC data, greater than 90% of white people, for instance, who have an indication for PrEP have actually been prescribed PrEP, while only 13% of Black people have been prescribed PrEP. And so we're of the mindset that we can no longer call this a disparity, right? Like this is, at this point, it's beyond a travesty. And that's why studies like HPTN 096 are so crucial because, you know, it's a novel study, it's a very innovative study by design with the goal of teasing apart the true root causes of these travesties. And this includes by examining multiple levels of influence, right? So not just sort of individual level things, but also looking at social and structural level factors. And so, you know, this is very important for us to, you know, hear from the folks who have organized the HPTN 096 study and hear about how they're, you know, hoping to intervene and sort of tease apart these issues. John?
Cool. And then the FAP Research Working Group is also proud to sponsor this webinar as well, because our mission is to ensure that HIV-related research, such as HPTN 096, at the NIH is funded at the highest level. With the recent threats to NIH funding from Congress, it is more important than ever that we let our voices be heard and allow studies like this to happen. Yesterday, the House voted to reduce NIH funding by $6 billion. That's billion with a B. And there is an amendment to reduce funding for the National Institute of Allergy and Infectious Diseases, or NIAID, to FY16 levels. That is $4.6 billion compared to FY23 levels, $6.5 billion. So that is almost a $2.1 billion difference and reduction in NIAID funding, right? So studies like HPTN 096 are being threatened imminently, and we cannot let that happen. So that is why this webinar is crucially important, so that we allow these studies to happen and to flourish and to produce the results that will allow us to end this epidemic among this population by 2030, because we cannot say that this epidemic has ended if Black communities are left behind still, right? So with that, we would like to really introduce and thank our presenters who will be talking about this study. And I'll kick it over to Riko to introduce the first individual.
Great. So thank you, John. So our first speaker, as we noted, was Dr. LaRon Nelson. He's an independent foundation professor at the Yale School of Nursing and director of the Justice Community Capacity and Equity Core at the Center for Interdisciplinary Research on AIDS, or CIRA, at Yale School of Public Health. Professor Nelson co-chairs the HPTN 096 study, and along with him, we have Dr. Cedric Pulliam, serves as the Principal Global Health Equity Consultant and founder of CDP Consulting, LLC, and the Health Equity Talks, or the Talks consulting firms, providing health equity and systems integration assistance in the HIV response in Ghana, Kenya, Malawi, South Africa, and Zambia. Additionally, Dr. Pulliam provides health equity consulting to various industry partners such as Janssen, Bristol Myers Squibb, and Gilead. He's a health psychologist by training and serves on the protocol team and community strategy group for HPTN 096.
Christopher Hucks-Ortiz is a public health professional who serves as the chair of the HPTN Black Caucus, a highly respected and knowledgeable body of research professionals who provide scientific and community leadership and cultural expertise for Black African American key populations in NIH-funded HIV clinical trials within the HPTN, the HIV Prevention Trials Network. Mr. Hucks-Ortiz has 20 plus years of experience in the design, implementation, and evaluation of HIV prevention, treatment, and substance use services. He also has a very strong background in the ethical conduct of clinical trials, HIV and others, ensuring culturally competent study designs for racial, ethnic, sexual minorities, and other disenfranchised populations. He serves as a member of the protocol team for the HPTN 096 study. And last but not least, we have Abraham Johnson, who has a strong theoretical background in public health education and HIV clinical research, as well as practical experience both inside and outside academic and rural settings. Abraham is passionate about ending HIV in marginalized communities, dismantling racist systems, and ending health disparities. His unorthodox approaches to public health and awareness of intersectionality is what characterizes his embodiment as the urban intellect. He is a published public health practitioner and HIV advocate whose experience in community health and HIV biomedical research spans multiple years. He earned a Bachelor of Science in Biology from Savannah State University and a Master in Public Health from Georgia Southern University. So now we will invite Dr. LaRon Nelson to start.
Okay, thank you, John, Riko, and Jim for that introduction. And I forgot Abraham went to Savannah State, so my hometown. Thank you, everybody, for joining this morning. I am one of the two co-chairs of HPTN 096, along with Chris Byrer. I want to start today with a little bit of history. And so I'll take us back, 18 years ago, in 2005, at the National HIV Prevention Conference, where there was some data released from a 5-city epidemiological study, which looked at about 1,800 MSM in the US. And in that study, they learned that 46% of the people who were living with HIV were Black. 46% of the MSM who were living with HIV in that study were Black MSM. Extraordinary at the time. And not only that, but that 2/3 of them, maybe like 64%, not technically 2/3, but most of those men, those Black MSM, did not know their status. And that set off alarm bells, almost 20 years ago, around what was happening. Given all the investments, the federal investments in HIV, how could it be that we had this many Black MSM in this one study who were living with HIV? And it led to a lot of advocates mobilizing to try to do something about this. That included the formation of the National Black Gay Men's Advocacy Coalition, or NBGMAC as they're commonly known. And a few years before that, I was part of a group that founded the Black Gay Research Group. It was in 2002. And so we got together to say we have to figure something else out. And so we convened in Charlotte, North Carolina to develop a national Black gay men's research agenda. That is available online. I think if you go to naesm.org, they have that hosted, so you could read through that. It's an oldie, but still relevant. But in that agenda, we outlined some principles about what we thought was necessary for research on Black mental health, sex, and men. And it wasn't just HIV research, but it was a big part of what we were concerned about. It was our genesis for convening. It was that it should be timely, that it should be primarily designed, implemented, and interpreted by Black people, Black men in particular, that it should be conducted across diverse socioeconomic groups, but that include age, that include income, that it should be funded by multiple sources, and at levels that were sufficient and what we thought were necessary to sustain those research efforts so that they could have a genuine potential to impact the epidemic. We'll come back to that. And that it should be conducted in partnership with Black LGBT organizations and individuals. And so that was 2005. So if we fast forward to 15 years from then, 2020, the situation still hadn't looked much better. So these are 2020 HIV diagnoses data. And if you look across all regions, that in that year, Black men who have sex with men comprise 38% of the diagnoses among all MSM. If you look specifically at the South, among MSM diagnosed in the South in 2020, Black MSM made up almost half, 48%. But that is, so I'm saying that is still unacceptable. How can we be this far past that 2005 study and the development of this agenda and our attempts to advance that through NIH and CDC and private foundations, and be at 2020 to still see this? But this is where we are. So I often use this slide, this graph, to try to understand this situation. I mean, people say, LaRon, how could this be? How could we have these? We have so much now. We have PrEP, we have different forms of PrEP, we know about treatment as prevention. How can this be happening? And so I think this is happening because we have been asking particular types of questions that produce particular types of answers. Important questions, right? In some ways, foundational questions. But the question that we have asked to date have been questions about efficacy. Does a strategy work to do a particular thing? Can suppressing HIV viral load prevent onward transmission of HIV to a sexual partner? That is an important, very particular question. You know, can HIV pre-exposure prophylaxis prevent someone from developing an HIV infection if they are exposed to the virus? Key, important question. Can a home device that's self-administered show reliability in detecting an HIV infection if one exists in a person who's self-administering this test, right? That's an important question. But answering those questions, those important questions, has led to dramatic reductions in HIV incidence among white MSM over this 10-year period that's shown on this graph. And it's not done much at all to address the epidemic among Black MSM. So this includes the leadership of HPTN 096 at the time, Chris Byron, Bob Remy, and myself, the HPTN Black Caucus, said we need to ask a different question. And the question is not, does particular strategies or products or devices work to affect a particular outcome? Because we know those answers, they have not helped Black men by and large. The question we needed to ask was, what does it take to stop the spread of HIV among Black men who have sex with men? Right? Not does PrEP work, does injectable work versus oral, does treatment as prevention, is that is undetectable, equal, untransmittable, not whether or not home tests work. We know those answers. The question that we have to ask from a research standpoint is, what does it take to stop the spread of HIV and Black MSM? Because when we ask that question, when we pursue that answer, it forces us to consider other larger forces that are all sometimes typically not in the domain of the people who fund this type of work. So I'll say, for example, we know that in the South, which is a place that really is the epicenter right now of HIV epidemic, is a place where racism has really systematically underdeveloped Black communities, historically and to this date. And that organizations who serve Black MSM, whether they are 11 of them or not, operate in an environment of systemic racism. This leads to a lot of important things. Limited funding opportunities for those organizations, because they're not, the work that they do are work that some funders are interested in, right? That has implications for us. So they have less resources. They are often, their capacity is stressed and stretched because they are working with people sometimes who have extraordinary needs. They're in very tough circumstances. So they're doing this work with very little resources. We've not invested previously research capacity for those organizations. You know, we've given it to the big universities. I'm at a big, well-funded university. That's where the money has gone. It's not gone typically into Black community organizations to identify and pursue research. So new organizations who have come up, you know, they're stepping up to try to meet this challenge, but they're new. They're not well established, don't always know the rules, and they face other sort of startup challenges that are typical in any new venture that's starting up. I think what this has done is led to this bias in the public perception about the possibilities for Black communities to lead the fight against HIV in their communities. We see it as sort of an inadequacy, but not recognizing that this is what we are seeing. What I think we're misinterpreting is the systematic underdevelopment as inadequacy of the organization, without understanding the ways in which these systems have set this up in ways that still have implications for HIV, for our ability to mount an effective local indigenous response to HIV in our community. So HPTN 096 is integrated strategy that was developed with that in mind, that the issue is not even that we don't have strategies or products or devices that work. We do have them, but there are barriers to Black MSM being able to access them, for them being able to use them, and to use them in an environment that is not subjecting them into stigma and discrimination. And that we had to figure that out. That we did not identify what are the structural determinants, social and behavioral determinants, and then endeavor to address them all together, that we would not change the situation. Because that is what it takes, to go back to that question, that is what it would take to stop the spread of HIV among Black MSM. And so our strategy, sort of represented by this circle, at the center of it does take into account PrEP, ART, and HIV testing. It's a status neutral strategy that's designed to prevent HIV and also to get folks who are living with HIV in treatment, retained, and to viral load suppression. And it does this by a strategy that looks at how do we increase equity in communities, in Black communities, and particularly among Black men who have sex with other men. How we use social media strategies to transform stigma norms and try to raise awareness about prevention and treatment strategies or efforts in local communities, offering peer support that provides emotional, affirmational, and educational support to Black MSM in communities. And then intersectional stigma reduction in healthcare facilities, which in many places, if not most places, are still the place where the men have to go to get care. And so even if that place has PrEP or treatment or testing, but if it's a place that is if it's a place that you don't feel safe or that you are not safe because people are going to stigmatize you, then the men won't go. Some might argue that because of the threat to the psychological wellness, they shouldn't go to those places. So we have to figure out ways to transform those places. And consistent with the National Black Gay Men's Research Agenda, we decided that we would do this study in partnership with local organizations that are Black-led or those that have a history of serving Black MSM communities. We're doing the study in 5 cities. All these cities are in the U.S. South. They are all identified as in HIV epidemic priority communities. These are the 5 you see on your screen: Dallas, Texas; Memphis, Tennessee; Montgomery, Alabama; South Florida, including Miami, Fort Lauderdale; and Atlanta, Georgia. The study is designed, we think, that will have results closer to 2028. It is a single-arm, interrupted time series study. We learned that doing a cluster community randomized trial was more complicated than I think that there was a simpler way to get the answers that we needed for this study, and this design is a simpler way. And so the intervention, this integrated strategy, will be implemented over a 2-year period. We expect it will start the first implementation midpoint 2024. We'll start with 3 cities: Dallas, Montgomery, and South Florida, so Miami, Fort Lauderdale. And then we'll start a second cohort of cities, which will be Memphis and Atlanta, sometime in 2025. Our co-primary endpoints are the number of clients who we get into services, whether that is prevention services or treatment services. We're also looking at PrEP uptake and retention in HIV care. And so, I went through this, and it sounds, elegant, and maybe in some ways linear. We have this sophisticated design and this study across these cities, but it was not without some challenges. This is a big bet, and it is a bet because it's a big bet, because we said we can't tinker around the edges on this thing. We have to go full throttle if we're not just trying to do another study and identify some data. If we're really trying to figure out how we're going to stop this epidemic among Black men who are sex men in the South, then we're going to have to take a big bet on this. And that meant convincing a lot of people that this was the thing to do. Because as John mentioned in his introductory comments, resources are not unlimited, and folks have to make a decision about how they will invest those resources. And so it was not easy to do. Many folks thought it was a good idea. Not everybody decided to come along with it. And there are probably some reasons, valid reasons why, and maybe some problematic reasons why. But we did get support to do this. This study is principally supported by the National Institute of Allergy and Infectious Diseases, along with the National Institute of Mental Health. Obviously with support from HPTN and a lot of operational support from the Centers for Disease Control. What NIAID, in their wisdom, did push us to do was to say, this is a big bet. We all accepted that if this worked, this could be a game changer for the country and for Black MSM and Black communities overall in the United States. But this could be a game changer. But because it was such a big bet, that we should do what they called a pilot, to just see what we can learn, because they were sure we learned some early lessons that could inform how we refined the study before we went fully into the field. And so we did a pilot in Dallas, Texas, and Montgomery, Alabama, and we did learn some things that have helped us think, be more fully informed about how we pursue this study. So these are just a few examples. First, we had local community input and advocacy that helped us reshape our health equity component, which initially was sort of centrally run, but that local advocates thought that this should be run locally, that we should develop local coalitions and support them to do the local work to address structural determinants and barriers to HIV prevention and care in those communities. And so we did that. We saw that there were financial crises in several cities, but one so severe that it led to the takeover of 2 major HIV service organizations. During the course of this study, we actually had 2 chief executives of different organizations in different cities who died unexpectedly during the course of the study. Not because of the study, but it's just to paint the context. This is all happening in these places. Their life is precarious, organizations are fragile, and all these folks are trying to figure out a way to stop HIV among Black MSM. This is the predicament that our country and this region finds itself in trying to do this. And then when we did our cross-sectional survey, we found a very high prevalence of HIV in that sample, higher than we expected. Across the 4 cities that were in that, Montgomery, Dallas, Greenville, South Carolina, and Houston, Texas, there was 50% HIV prevalence in that sample. Sobering. This is just showing you what I just said, but across the 4 cities, overall, the prevalence of HIV was 50%. Much higher than we anticipated, but consistent with what had been predicted by CDC some years ago. So one of the things that we wanted to learn from the pilot, one of the things that was sort of the big bet was whether or not communities would do this. Could you get communities to work together? It's a lot of bad blood in some places and drama and maybe some disorganization. Could communities work together to do it? So we know the answer is yes. We established coalitions both in Dallas and Montgomery, Alabama. You can see their photos there, the Dallas Equity Coalition and the Honest Coalition in Montgomery. We can do it. It can be done. In addition, we're working on community development programs for Black MSM that focus on leadership, personal and work skills development, and also incorporating some entrepreneurial principles that can lead to economic justice. Because in addition to trying to figure out how to get people on PrEP or into treatment, we have to figure out ways to shore up and build infrastructure in these communities. And so we're working through the health equity component of the study to do that as well. The other sort of challenge that folks were concerned about was, could you get healthcare facilities to do intersectional stigma reduction intervention? Is it too big? Is it too much? Would everybody do it? And so we tested this also in Dallas and Montgomery across 4 organizations. The answer is yes, they'll do it. We can get them to do it. So all the green is showing you is that these were milestones that we set that were accomplished. The issue is not so much that folks wouldn't do it, that organizations wouldn't do it, that communities wouldn't mobilize to the coalitions, but that it hadn't been tried. We had not asked that question, we had not attempted to do it, and so we know that this is possible. And then another innovation I'll just mention is that we were able to synthesize federal resources, again, because they're limited. One outcome of that was the development of an intersectional stigma measure. This was actually developed by Dr. Lisa Boleg in her R21 study in 2 cities. They had done the work to develop it. What we offered in HPTN 096, because of the scale of our study, was to apply it. So we were able to get it into the field, to administer it to over 400 Black MSM and to validate it. And so now the field has a validated intersectional stigma measure that we didn't have before. And that is the measure we intend to use as we go forward. So just to say that the community is centered to why we're doing HPTN 096 in the first place. That as complicated as it is, those challenges that I outlined to you, that where there is a will, there is a way. And in these communities, there is a will. I've been stunned at just how much folks have come together to make sure this study can be successful in these communities. And we cannot do it without communities. And I think the reason it will be successful is because we have tapped in to a community spirit who wants to see this done. And I think they're happy that there's federal support and researcher support and advocacy support to have it, to complete it. And then when we talk about equity, our thought about building capacity is in equity, and not just can we produce an equitable outcome, but in how we do the research. And so our focus on partnering with local Black organizations, on involving communities in every aspect of HPTN 096 is our way of demonstrating equity in how we do the research, not just in trying to demonstrate equity in our research outcomes. And so in conclusion, what does it take to stop the spread of HIV among Black MSM? I think it takes implementing this integrated strategy that I outlined, so that devices and strategies and products like PrEP and testing, injectables, treatment as prevention can work. But we have to do it in a way that both acknowledges, anticipates, and responds to the realities of anti-Black racism and anti-LGBT stigma and discrimination that has prevented it from having the impact to date that it should have had. And not just reducing stigma and discrimination, but also identifying local Black and LGBT assets and finding ways to support them. Because I think the answers is in communities, but we have under-resourced them. And this is a new way that we use a study to also find ways to resource communities to do this work, but that is what we're trying. It is an experiment. We don't know if it will work. It's a study, we're testing it, but we have confidence that the strategy will work and that it can be scaled up across the country. Thank you.
Thank you so much, Dr. Nelson. We are going to move to Christopher Hucks-Ortiz.
Excuse me, wonderful. Good morning, everyone. I hope you can hear me very well. So I'd like to, first of all, thank you all for the opportunity to be here this morning, along with my esteemed colleagues. As we just heard Dr. Nelson speaking about, we heard from him about some of the importance of why this work needs to be done, and some of the importance about the role that he mentioned of some of the stakeholders, including organizations across the country that are Black-led, and some of them who have been partners within the planning and operation of the HPTN 096 study. I'm going to take a step back just a little bit, because when we start to talk about these, and Dr. Nelson referred to the very beginnings of all of this, where himself and Dr. Chris Byrer and some other folks, including representatives from the HPTN Black Caucus, came together. This was what became the synthesis of the idea and the intervention packages that we're now looking at as HPTN 096. So because the members of the caucus were represented in that, included in that space, I'm just going to talk very briefly about the HPTN Black Caucus and some of the work that we've done that many of you actually may be familiar with, just didn't know that this work was coming through and informed by the HPTN Black Caucus within this space. So the Black Caucus within the HIV Prevention Trials Network originally formed, oh Lord, was it 2008, 2009-ish? And the reason that the caucus was created came out of some advocacy efforts that were led and by key stakeholder partners, including the Black Gay Research Group and folks from MBG-MAC that Dr. Nelson referred to earlier. And part of the reason for this advocacy, and there were other stakeholders as well, but part of the reason for this advocacy was that this was this large, new, funded opportunity to try to look at a series of interventions and questions about, if you create this package of resources and services for Black, gay, and bisexual men, will they take it up, right? It was really trying to help address some of these questions about ways to try to address the gap between services that might be available, including those in a research context, and whatever, and this disparate impact of HIV among communities of Black, gay, and bisexual men. So ultimately, what ended up happening, so this body of folks were organized and developed. The interesting thing about the caucus is, while we all have sort of, this outsider perspective of what's happening within the world of clinical trials, public health, social services, public health research, right, advocacy, policy, there's a variety of skills and backgrounds that myself and my colleagues bring together. But we also have a role to play inside within the network, where we also have the opportunity to have relationships with some of the lead investigators who are doing some of this work across the country, and many of them even outside of the country, who are funded by the National Institutes of Health. Some of the work of the Black Caucus, you'll see, has really helped to sort of frame and provide some structure and some guidance and some leadership to studies such as the HPTN 061 study, again, also known as the Brothers study, which existed in 6 cities across the United States. Many of you may have heard about what was known as the HPTN 073 study. The 073 study was the study that validated some of the information around PrEP uptake and acceptance that we saw in the IPERC study, but really kind of validated it for the lives and lived experiences of Black men across the country. So it was a study that was completely designed by 4 Black gay researchers, including Dr. Nelson, Dr. Sheldon Fields, Dr. Leo Wilton, and some other folk, including members of the Black Caucus, who were present to help design and develop and inform how this study ran and operated. The importance of this work was that the numbers of Black men in the IPERC study were really, really small. And when we think about like generalizability of research and clinical trials, we needed to see some more work that was done in that space. So the 073 study was done. We saw some great outcomes, including really high rates of uptake, really high rates of retention, and it really kind of changed some of the narrative around acceptance of PrEP and what that means in the conversation about PrEP and Black gay and bisexual men. There were a couple of things that followed that. One study that I'm very quickly going to reference is the 078 study. The HPTN 078 study was looking at this package of social services provided for men who are already living with HIV in a couple of cities. They were not expressly trying to oversample Black men, but what they found in this study was that a significant number of Black men were coming into the study trial and receiving this package of social services, case management, a variety of other things to try to address some of these social and structural determinants of health, and saw some very interesting sort of outcomes that came from that as well. So as that study was sort of wrapping up its work and some of the analysis was being done, there was some other work that Dr. Nelson had done through the 073 study. And the researchers all came together to say, we both have some really interesting outcomes. What do we want to do to try to address this need even broader? And so this original meeting was called, and I was asked to attend, and I'll be honest with you, when we walked into that room, I don't think any of us realized exactly what we were going to be doing in that moment. We started to have conversations about what the needs were in our communities of Black, gay, and bisexual men, and what might need to be done to try to address that. We looked at some of the information from the 078 study. We looked at some of the information from the PrEP study, 073. We looked at some of the knowledge and research and resources that were coming out of the HPTN Black Caucus and other key stakeholder groups and other aspects of the research, and really kind of started to look at piecing together and addressing what are some of these variables, what are some of these gaps, and what might that look like to try to address them. So all of those sorts of things ultimately helped to shape and inform the study that we're talking about today. And part of the reason that I wanted to kind of touch on all of this is because when we talk about health equity, and much of the work that I'm doing now is in the space of health equity, we have to look at when we start talking about clinical trials, what is this gap, right? So as we heard Dr. Nelson sort of speak to, we have this significant rate of acquisition of HIV, and what this looks like and who's impacted by that has changed. But if we're going to ever get to the end, as we noted, of ending HIV, whether it be by 2030 or hopefully earlier, but perhaps whenever that happens, it's going to happen by addressing the needs in all of our communities, including communities of Black, gay, and bisexual men and other Black key stakeholders, our key populations. I will say that within the network, the work of the HPTN Black Caucus, while it may have started expressly looking at the needs of gay and bisexual men, the caucus now works, has expanded. And so rather than just focusing on any one particular protocol, the members of the caucus now actually are included and respond to and speak to all of the key protocols looking at the lives of Black men who have sex with men and women and trans populations and people who may use drugs and people who experience challenges about stable housing, et cetera, all of these folks, when we think about how clinical trials are done and how whose needs need to be addressed, we get the opportunity to advocate for that in this space and work with some really, really amazing researchers. So very quickly, and then I'll wrap up. Why is this work important? As we know, from an equity perspective, there's this big gap that needs to be addressed. I think that if we can find ways to try to demonstrate through clinical trials such as this one, that there is a model that, and again, we don't know what the outcomes are going to be, but we're going to test this model. And one way or the other, we're going to learn some information, much of which we hope will be generalizable and help us all to change or improve the way that we are working together to impact the epidemic in our country. And with that, I'll pause. Thank you.
Thank you for that background and context, Christopher. You know, it's really sort of, you know, exciting to hear, exciting and also, you know, a bit sort of disappointing, but just to hear all of the, you know, the work that went into forming, you know, the study and kind of getting all of you into the space and into the room to conceptualize it. We do have some questions coming in from the chat, and so we're going to get to those questions for you and for Dr. Nelson. But I do want to pass the mic to Dr. Pulliam now. Cedric, if you can join us and, you know, share a little bit about your perspective as it relates to pulling this team together and this vision for 096.
Yes, thank you, Riko, and thank you, Chris and LaRon for setting the stage up for today's webinar on HPTN 096. So my role uniquely with this study started when I was at CDC as a federal government employee working in the HIV prevention division. It was brought to me by a colleague in one of our HIV diagnostics working group. It's a divisional working group. And I had not necessarily heard about it. I just heard, you know, things in the background about it. And reviewing it, I instantly said, well, who from CDC is involved, and got some of the details and the specifics, and, you know, said, I want to be involved. How can I get involved? And that was the moment after reviewing what the focus of this study was going to be, the different interventions, and learning about truly background and foundation and why this is so key and so important, and knowing as a public health practitioner, because I say that and caveat it as a lot of the folks that work in federal government agencies, even though they may have started in the beginning of their careers doing community work and testing and maybe even doing clinical research and clinical trials and such, a lot of them are so tapped out of that or not tuned in or tapped into that atmosphere in today's sense. Like in 2020, I'm talking when this was brought to my attention in 2019, 2020 timeframe. They are not doing community work. They're not, you know, working with CBOs and doing HIV testing or in tapped with advising community-based organizations. And that difference is because I do that, and I've done that my entire 13-year career with the federal government, because I knew how important you must stay tapped in and understand what is happening on the ground versus being behind a desk in a federal office. So I put that caveat in to really, you know, hone in on that, because it was significantly important for my particular role with the study. And the moment after reviewing and having a discussion with my colleague at the time, I was also brought to my attention the issues around the funding. Going back to that slide, the Shark Tank slide on LaRon's presentation, around other individuals in various agencies across the federal government not really wanting to back up this particular study. It was a big bet, as LaRon mentioned. However, it was something that we needed to do and needed to fund. There was so much federal interagency advocacy, championing, and really telling individuals kind of almost like the ethos of this study, why it is important and why we need to make the leap and fund this study. And there are so many individuals that back this particular study and supported. And hearing conversations around that was very good for me to know that this study did have support. It did have a good rapport, and people wanted to see it come into fruition and actually happen. So that was really something that resonated with me through the process of being a part of the 096 study. I think listening into protocol team calls and seeing that process, it was my entry into this space, right? Like seeing how the HIV Prevention Trials Network and these larger studies, how that process gets built up was very interesting. But then over time, over the years, I had left the federal government. And when I was in the process of leaving the federal government, I was asked to join the community strategy group of this study. This was significant because, again, being tapped in, moving from DC back down to Atlanta, Georgia, was a significant piece because I was already thriving and really working with community organizations in the Atlanta area to understand sort of, what their barriers are, their challenges are, what populations are they specifically honing in on, et cetera. And I also was doing that from my CDC role, right, in my HHS role. And so this was all very important to bring to the table from the community strategy group, because on the community strategy group, there's so much lived experience, community experience, intersectional thinking, broad mindsets, and broad retrospects of how we should be implementing things, a part of the different interventions of the study, and providing the co-PIs and the full actual study team with a vast amount of insights and alternatives and things that should be changed or things that should be considered significant, how to approach community, how to approach the organizations before, partnering with them. And it was so many elements that we really did help and continue to help as we continue to meet on a monthly basis to really make sure that the study is successful. And when there's barriers or challenges from the study team, depending on what location, they bring it back to us and we address it and work through different resolutions that could potentially help mitigate the issues. So I also want to say the importance of the community strategy group is also in a sense of a capacity of strategic thinking and planning. And seeing that we had to do this sort of pilot study based off of the funders of the work, it was also important to say, okay, how do we strategically think sustainability wise and ensuring that this study has this sustained funding throughout the entirety through, I believe what LaRon mentioned was 2028. And so that was also something what do we need to do? How can we do it? What do we need to activate? Those sort of things. So I just wanted to put out there sort of the experience being a federal government employee, moving and transitioning to a civil society organization and a global HIV response employee, and really why it's important to realize that so many people that are doing the funding of these important studies sometimes don't have the touch points and the knowledge of what's really happening on the ground in the field in community. And it's rare. It's a small amount of us that do have dual touch points as full practitioners in this work. And that was my significance of both being, and I still serve both on the protocol team as well as a community strategy group for 096 study. And I'll conclude there because I know we have Abraham up next, and of course a lot of questions I see popping through the chat. Thank you. Back over to you, moderators.
Thank you, Cedric. With that, we will also pass it over to Abraham Johnson. Abraham has been, working deep in the weeds with the 096 team, kind of, testing out interventions and testing out spaces as it relates to, making sure that spaces are welcoming to Black gay men. And so I would love to allow you this time, Abraham, to tell us a little bit about kind of your experience and how you've been able to contribute towards this work.
Yes, thank you so much, Riko. Before I get started, just a quick disclaimer. I'm currently employed at Gilead Sciences, but I'm speaking about my work I did before I joined Gilead and while working at FHI 360 and TAG. So first off, thank you both, Dr. Nelson and Chris, and also you, Cedric, really setting the foundation around what the study is about. My uniqueness to the study came in twofold. I actually worked at FHI 360 as a community programs associate, and I was there at the beginning of the study when it was in development, and I got a chance to really provide some technical advice around what the study would look like in the South. As a person who has lived and breathed, and as a gay Black man in the South, I really was very passionate about the study, because I know Dr. Nelson said that they say it's a bet. I will always bet on my community, and any chance I'm in the room to really talk about what it means to be Black and gay and live in the South, I'm gonna put all of my money on the line for. I know I don't make all the decisions, but I just want to put that out there. We are worth it. And I got a chance to be a part of the client instructor component, which was the culturally responsive intersectional stigma intervention. And by that, I was a client instructor, and there were two cities, Montgomery, Alabama, and Dallas, Texas. And I would go in as a almost as a mystery shopper, as a persona, and we were I was given a persona to either receive treatment or also try to gain access to PrEP. So the clinics were aware that I would come in as a mystery shopper, and I would have like different a character that had different personas, such as a person who may be living with HIV, a person who has a history of drug abuse, or a person who may be unstably housed, for example. And what I realized, that there's so much work to be done as it relates to navigating the healthcare system as a Black gay man. Even though these two clinics in both Dallas and Dallas, Texas would know that I was coming, a lot of times the things that I knew I would experience, I experienced. For example, I would go in and give them my persona name. I say Devontae, for example. Hey, I'm Devontae. I'm here for my first visit as a person living with HIV. And sometimes they would just look at me like, oh my God, what to do next? So like, okay, can you have a seat? And so I would have a seat. They would, I would go through the first initial visit. And for those of you all who haven't navigated a healthcare system as a Black person, the first visit while living with HIV can be one of the most daunting things, because you meet so many people. So I remember I was at a particular clinic or Federal Qualified Health Center in Dallas, Texas, and I met with the social worker for the first time, and she says, "Oh, I know that you're in hell right now, but I promise you, it's going to be a better. It's going to get better." Now, here's a white woman telling a person of my character that, "Hey, this is my first visit," and that I'm in hell right now. So I remember I cringed a little bit. I was like, "Oh my God, I can't believe she says that," but I'm staying in character. So then we finish our visit, and then I would go see the doctor, and the doctor and I would discuss like my treatment journey, and I would do some pushback around like, "Hey, I don't think I'm ready." And this was all based on the model of stages of change. So I would push back a little bit and to give all the things that will make it challenging for me to essentially either access treatment or access PrEP. So after the back and forth, I would then like get out of character, and I had a chance to really train the provider on some of the things that they would do wrong, or some of the things that they did really good at. And that was my favorite part of it, because when Black gay men enter that waiting room, that's when the work really begins. It can either change the narrative of their life living with HIV, and or their ability to really benefit from products like PrEP. So oftentimes providers, they still have a hard time really communicating with me as a Black man. Like, I really thought that was like really interesting. Like, sometimes they would skirt around language, or kind of really didn't know how to perceive me. And again, I'm a character, right? So I would be in full character mode, because I'm in community. So I know some of the things how people sometimes show up when they go to the job. So sometimes I would be nervous. Sometimes I would be super, super depressed. And it's just amazing how they would have to kind of like struggle to really get out just have a conversation. And whether it be asking, "Hey, how was your trip to coming to today's visit? I know that there's probably a lot going on right now." Those small things, really, I had to teach them soft skills. And I know maybe those skills aren't being taught in medical school, but a lot of providers are still not culturally responsive and not culturally humble when it comes to serving Black gay men, whether it be the front desk, the medical social workers. I think that across the board in the South, we are still experiencing racism in the healthcare system. And these are things that I think that all of us on this call know about. But what I really appreciate about HPTN 096 is the opportunity to really train providers who are doing work in the South on how to do it better. And it's all about the willingness to participate. But all in all, I really enjoyed being a cloud instructor. It created moments of vulnerability, moments of frustration, but most importantly, opportunity. There is so much opportunity in the South to do work with healthcare providers and healthcare facilities. I am still betting on ending the HIV epidemic globally, but especially in the South, because it's such a unique, just a unique place. So I know we have Q&A. I just wanted to put that out there. Thank you for having me. Also, Liz and Rita, you all were such a great support in the client instructor process, because there were a lot of things we had to change along the way, but I'm looking forward to the dialogue and even asking more questions about my role as a client instructor.
Thank you so much, Abraham, for that experience and articulating your experience as a client, a mystery shopper, if you will, to some of these clinics in the South. We do have a follow-up question, and now we're gonna thank our presenters for their perspective on the study. Now we're gonna switch over to kind of questions that have been coming in through the chat. We have some prepared questions, but this is the opportunity to ask questions to any and all of our presenters, right? We have the opportunity, they're here, they're available to answer all of your questions. Please take advantage of their presence on this webinar right now. And just as you were talking, Abraham, a question came in, was like, was your experience with Black providers different than non-Black providers? How were those nuances different? If you can share your experience.
So surprisingly, I only met with white providers, only whether it be nurse practitioners or physician assistants. Mainly anyone I interacted with in Dallas, Texas, they were white.
Okay, good to know. Another question from Julie Patterson. Dr. Nelson, I'd love to know how HPTN 073 and the C4 client-centered care coordination success fits into this study. Are you integrating it? She's such a fan of C4.
Oh, thank you. I'm a big fan of it too. We did it. We thought about it, about integrating it. I think so C4 is publicly available, and it's actually being studied in some other implementation studies, one in New York and DC, and one in Toronto, Canada, as a matter of fact. The challenge we had was it would require like sites to adopt that practice. And so what we did, instead of having them adopt C4 as a particular model, we did take some of the elements of self-determination theory, which C4 is built on, and we incorporated that in the intersectional stigma reduction program that Abraham described his part in. And so we do talk to folks about what it means to provide people with support for their autonomy. What does it mean for the Black gay man to be able to make the decision that he wants? And how do you find ways to support that? Because in what we saw, and maybe what we still see in places, is that providers have an agenda, something that they want you to do. And that's, if it's to take PrEP or to take a test, like that's what they want. But that is an exercise of power, according to self-determination theory and in C4. And so while we're not using C4 in 096, we do help providers figure out ways to minimize their exercise of power or domination over the healthcare decisions of Black men or Black gay men. We work with them to figure out how they can support the men's ability to master or accomplish whatever goals they want, to help give them agency, and also to demonstrate that they care unconditionally, meaning they don't only care if you do what you ask them to do. Like they care, period. and that you can try this or not try this, but I'm still here for you. You can come back and we can figure out whatever else is going to work for you. And so we do incorporate those principles in how we try to teach the intersectional stigma reduction in the healthcare facilities, but they don't actually implement C4. But thank you for recognizing that.
Thank you, Dr. Nelson. We have another follow-up question for you, Abe. So a couple folks want to know sort of if you could give us, insights about what the reactions were from the providers that you met with, and how receptive were they to the feedback, how critical, to the critical feedback that you gave them from your interactions, and what have you been able to do with that feedback?
Yes. The good thing I can say, most of the providers, well, almost all of them were receptive to the feedback. I can say in Dallas, most of the providers do recognize that they have a disconnect with some of the patients, but mainly Black patients. So when I would, after I would give them feedback, we would role play again. So for example, I would say, you instantly jumped into like talking about prep and treatment. You never asked me how I was doing, or is there anything that I need? Really just addressing those social determinants of health. And I think a lot of times they would say, well, in real life, I only have a short amount of time to spend with patients, and I try to get to the treatment aspect of it because it's really important. But I told them sometimes you miss an opportunity to really build that rapport with your patients and figure out what their needs are. That way you can bring in your social worker, bring in your therapist. I think that a lot of clinics still work in silos, and the social worker doesn't know what how to get with a therapist. And I'm like, have you ever thought about, if I say, hey, I'm feeling really, really depressed today, have you ever said, hey, well, would you like to speak with our peer navigator? Oftentimes that will miss they would forget all about the other social support service, and it's will be housed in the clinics that they say. So I would say, hey, you could have easily brought in someone and say, hey, I'm willing to step out the room and you can talk to such and such and let you all talk about what it means to start prep. I don't think they know how to gather resources, but I think that a lot of times it seems a bit like reservations around how to communicate with Black people.
Let me add to that, because thank you for those, Abraham. One thing that I think in many cases we have going is that most of the providers want to do good. Like they really want to do well. And most of them are doing their best and they think they're doing well, but most of them have never had a Black gay man stop them and say, hey, here's how you got it wrong. And here's how I'm going to help you. Here's what you would do if somebody asked you this question. This is what would have helped me. They've mostly only experienced Black gay men as patients who aren't going to challenge them in that encounter where you need something from this person. And you're not going to check them. Some people might, but overall, they don't complain. And so they don't even have a sense that they did something that was wrong. So the Black gay men wouldn't complain. They just wouldn't come back. They just know, I can't go to this place. And so what Abraham is offering them is the chance to not criticize them, but to say, here's what you're doing, and this is how it's landing. And so you might be oblivious to it, but it allows them to have a different experience with a Black gay man who is now their teacher, who they may have never had a Black gay man teach them in medical school or nursing school or PA school. And so I've also heard feedback that they really value the feedback they get from the client instructors. And I actually met with administrators at USCHA who met with me to say that they still talk about it. When they have these meetings, staff meetings, and something comes up about a patient, like somebody will refer to Abraham and say, remember, this came up and he said this, how you should do it. So they were, that's an enduring effect of this, and shows that the way you provide feedback can make them able to receive it versus them being defensive about it. So I just wanted to add those comments too.
Thanks, Dr. Nelson.
Thank you so much. Shakina, I see your hand.
Thank you. My follow-up question to Abraham is more of a feedback question. The Pennsylvania HIV Planning Group is looking at a study on stigma, and we've just finished a very in-depth intervention process to identify waiting rooms. And so Abraham's highlighted the importance, and we all know, but a lot of organizations fail in this area. They like conversations, it's just not done well. And so I'm kind of curious, Abraham, on your feedback on the kind of overlap between the waiting room experience as well as the conversation that providers are having, as well as any kind of like language justice that's impacting. I mean, I connect all these dots on a regular basis in identifying. Would you believe and say that this is also contributing to medical distress and retention in care?
Yes, thank you so much for your question. There were two types of visit that I failed to realize. One is when I would give feedback to the provider, and the additional visit, I would go and observe. So just observe, like the waiting room, I would look at the imagery on the wall and figure out if it's outdated, what doesn't resonate with me. And I think that something that one clinic did get right was that their waiting room was very inclusive. It had a lot of Black imagery, Black art, and not to the point where it was just like overdoing it. It was just subtle. You just felt like, okay, this is the space that I feel comfortable in, whether it be a Swerve magazine or something on the TV that wasn't necessarily just so HIV related, but something that I just could watch to take my mind off of being about to seek service for HIV, something that is heavily stigmatized. So I totally agree that the waiting room, it has to create an aesthetic that doesn't feel so sterile. One of the clinics in Dallas is really sterile, and I think that's because by sterile means it's very like Johnson, like they would just call your last name and you walk in, it's like, oh, it feels like you almost are going to emergency room almost. So it didn't resonate with how I would want to feel when I'm getting treatment prep for HIV or PrEP. So I definitely think that there's some a lot of correlation with that, and I think that also being able to really once the person calls you back, that's another thing. If a person calls you back, visits the phlebotomist or whomever, they also have a role in the patient journey where they'd be like, hey, what are your pronouns? How are you doing? Sometimes they would just call you back and like start checking your blood pressure. I'm like, first of all, I'm supposed to get my blood pressure checked. I have to get out of character. Like, this is not part of the visit. You actually supposed to just walk me into the room. But yes, I thank you for your question. Hopefully I answered it.
Thank you, you did, and gave everyone kind of a really good context, because this is an everyday experience, I feel, that's happening across America.
Perfect. Thank you so much. And I see there's a question in the Q&A that LaRon is typing as we speak, but I'm just gonna uplift it live because this is such an important question by Maximilian Boykin. How have elected officials been engaged in the process and interventions recommended by 096? And how have intersectional issues such as housing, criminal justice come up in the advocacy from the coalition?
Mm-hmm. Thank you for that question, Max. So both the coalitions are in the process of thinking about how to engage with elected officials. There are some in Dallas and in Montgomery that have been informed about what 096 is and what's happening in those communities. I think part of what we've done with the group called Southern Black Policy and Advocacy Network is working on building their comfort level and capacity to know how to engage officials strategically. There is still some unease about the topic, Black gay men and how to engage elected officials, regardless of, what a party affiliation, to sort of engage with the topic. There's been some of that, but what they're working on now is trying to figure out what sort of strategic ways to engage elected officials that allows them to see sort of their stake in it and contribute to it without causing political problems, which might undermine that type of engagement. So it's definitely what we're working on with them. They're also in the process of developing or documenting the local needs, like what are the issues that are coming up for Black gay men in these communities. I think even though they haven't all officially finalized those documentations, they already know that housing and police involvement are key issues. Dallas in particular has had a lot of involvement with the law enforcement community and helping to think through some of, maybe I shouldn't characterize how they're involved, but they're definitely involved. I've been to meetings where they've shown up, where they've spoken, and they're trying to figure out what they can do to help support what's happening. I haven't seen as much of that in Montgomery, but as they identify what are the sort of pressing local needs, if that is one that still rises as a priority issue, we'll work with them to figure out how to help address that, not just through working with officers, but helping people figure out if you need to get to appointment and it's across town and your PO is telling you got these parameters, like are there ways to work with that so that those don't become barriers for people or limitations to jobs or housing. So it's still very early in that point. We're moving from the pilot to the launch, but I expect at least in those first two communities, we'll have a better sense of how those play in and what the coalitions will do about it. Oh, let me mention something else to that. We sort of talk about these separately, but it is one integrated strategy. And part of what we're wanting to happen is that some of these issues, like what Abraham mentioned, some of them get identified in the clinic, maybe in real time. And so what we're hoping the coalitions will do, what we're encouraging them to do, is to be in sort of regular liaison with the healthcare facilities who can say, I got a patient who can't come, and this is why, because something that's related to housing or something that's related to this. And so that the coalitions can take some of that input and figure out how they get together and figure out how to address those problems. That the clinics can say, here's what's keeping our patients from getting access to this or access to that. And so some of those other intersectional issues might come out that the clinic themselves might not be able to address, but if they can be in liaison with the coalitions, that community advocacy can be done to help address some of those issues that still impact in the clinic, even though they're not technically clinical.
Thank you for that, Dr. Nelson. So there has been some interest expressed in the chat, not publicly, privately, interest in this intersectional stigma measure. And so as someone who was involved in the process working with Dr. Lisa Boleg on developing that, I can take executive sort of privilege here and say that it's not out yet, right? It will be out soon, hopefully within the next year. But I think that there's going to be a lot of interest in this measure and sort of, seeing what the 096 study team is able to do with it and, what other folks are able to do with this measure once it sort of becomes more available and accessible. But I can, definitely also speak to the fact that a lot of this stuff that we're mentioning here, right, sort of, how are you treated when you, how are you greeted by receptionists at medical providers, or how you, treated by the other staff within a clinic, from the janitor to the doctor to everyone in between, right? And so think about sort of housing instability and all of these sort of social structural barriers. These are all sort of baked into that intersectional stigma measure that, I think a lot of folks are going to be very excited to see when it comes out. And so we had another, yeah, go ahead.
Can I say something else about, because I think it was also important, because I think sometimes in these trials, these efficacy trials, that people don't fully understand the power that qualitative research can have. So I know there was a lot of work done to develop that we didn't have time to do, and we probably didn't have the right expertise to do it. But when we presented the results to Lisa and some members of her team, and I think she was astonished because, usually when you do these measurements, it doesn't always land right. You got to tweak some things and maybe do it again. And it was perfect. When I say it was perfect, I mean, everything held together. We put it in the field one time, and the reliability coefficients were, the lowest one may have been 82, but between like 82 and 91, which meant they all were measuring what we thought they were supposed to be measuring, which was extraordinary. But we could not have done that had y'all not spent years developing it? And she talked about, drama she had with people and wondered about how much time it was taking to do it. But if y'all had not taken that time to do it, we would not have had this, right? The field literally doesn't even have a measure of this. And here we are doing a trial that's sort of out ahead of our ability to even have methods or measures to monitor it. And so that was a unusual and extraordinary finding from that study. So kudos to you and the team for the work you did on that.
Thank you for that. Yes. And if it, for context there, that is probably not by happenstance, right? Because the measures and the items were sort of developed and tested with, medical clinic populations of Black gay men in Washington, D.C., or the D.C. metro area and Jackson, Mississippi, right? And so that's sort of, I think, is a part of the reason why it worked out the way it did so far. John, you have a question for us?
Yeah, one question that we wanted to pose is, how do you see the HPTN 096 study potentially becoming a possible model for future HIV research studies, meaningfully involving people living with HIV in communities that are disproportionately affected by HIV? And what advice would you have with HIV prevention researchers when it comes to working with NIH and doing this kind of Shark Tank kind of shopping around to get more buy-in for why this is an important study? Any advice, and how do you see this as a model?
Dr. Pulliam, you want to respond to that?
No, I think that this could absolutely serve as a model. What I think is important, and I looked through the participants list, right? The ones, I know the registered list is a lot larger, but the participants list that has been on the call, and I barely see any of my former federal public health agency colleagues. They need to be joining webinars such as this because they did make the investment. They've acquired this pilot phase so that we can, see how things go and then go into full implementation of this study. But ensuring that they stay in tune, and this is why I always harp on the practitioner piece, because a lot of times they do things and then they go back to the desk, back to the laptop or computer, and then almost not say disregard it, but not staying tapped in as to what the updates and what's going on until like maybe an annual meeting or something on that nature. I think in order for this to become that kind of model, we do have to, and what Max mentioned, engaging, and what LaRon talked about has happened in the pilot locations, engaging politicians in the local areas at various levels to really engage them, regardless how difficult and how resistant and stigmatizing the topic may be. This is a part of the social, behavioral, and cultural change element that this study has embedded within it, right? And that's for the politicians, the local leaders. I saw churches mentioned, and I saw a response on that. These levels have to be engaged in order for this to be that future model that when we look at this specific population and the HIV response. Over to you, LaRon.
Oh, I wanted to ask,
Abraham. Go ahead, Abraham.
quickly, Cedric or Dr. Pulliam, one of the things that I think this model really underscored the need for community advisory groups at the beginning of the F studies, and also the ability to pivot. I think that what I like most about the study team were their ability to pivot, because community changes, community evolves. And I think a lot of times we did a lot of strategize on how to get it right, whether it be like a 2-week period, like we would get communication about, hey, we're just working on the background, getting things right. But also when it was time for us to voice our opinions about what was going wrong from PIs, from the community strategy group, they actually listened, and being able to really take that feedback and apply it to the study. I think that's something that needs to be done moving forward. It's really how having community advisory groups and strategy groups at the beginning, and make sure they're diverse and being able to pivot throughout the study. So I think I just want to really emphasize the need for having community advisory groups on clinical studies.
Great, thank you so
Also,
much.
and one more thing, I think that we were incentivized for our participation. So I think that was another thing, like getting our expertise and like really giving us opportunities to be a part of the study through jobs, postings. So that was another thing that really can be a model. Really, if you're going to use community input, how do you pay them for their social awareness of what's happening?
Great. Getting paid for your expertise. What a novel concept. Thank you so much, all of you. I have one last question. I wouldn't be one of the founding members of PIBA if I don't ask this question. One of the, so PIBA, the Prep and Black American Coalition, which works to engage community leaders, health departments, and legislators to address the pervasive systemic barriers that prevent the Black community from accessing PrEP. Last year, we published the FUPU report, which had 3 recommendations: energize the Black public health workforce, educate the Black community on PrEP, and support a federally funded national PrEP program. How do you see the results and the findings from HPTN 096 being utilized to address any and all of these recommendations?
Well, I might not remember the 3 that you mentioned, but I heard you say the Black workforce. I think that part of what this can do is really help the Black public health workforce, including clinicians, to understand their role in PrEP and promoting PrEP. I think that part of what we sort of think about is the work that the places where we need to be on PrEP are not HIV care clinics necessarily. We need to be there too. But these are family practices, primary care practices, walk-in centers, many of them are not thinking about this. I was at a meeting of the National Black Nurses Association. The president is a nurse who does HIV work, Dr. Sheldon Fields. But we're talking to them about testing and sex. We were saying things like, we did a demonstration on stage where we used language like anal sex and talking to this Black woman about pleasure. And they were kind of, these are all nurses, but they don't typically go there with the patients that they see unless you're working in a place that is doing PrEP work or HIV work. But we need all of them to do that. And I think, I don't think any of these people are people who don't like, or most of them probably, it's not to have anything against black gay men, but they may not fully be aware of the ways in which they stigmatize. Abraham talked about his experience mostly only with white providers, but Black gay men go to Black healthcare centers too, and they don't get treated well. And I think sometimes they're not aware of some of how they practice, how it is a barrier. If you don't ask the guy about his sexual behavioral practices, or you assume that he has sex with only with women, only vaginal sex, and then you say it. So the fact that you said it already communicates to him that I can't. This person already got me pegged. There's something else. This conversation is over. I can't even go there with them. Those are barriers to PrEP, and I don't think they fully appreciate that is what's happening. And so what I think this does is help them understand the ways in which we, healthcare providers, are part of the problem. The stigma that happens in these places isn't just coming out the air-conditioned vents. We're creating it socially. And I think when they understand that, because I think they want to do well by patients, that they can take some of the lessons that we learn from this and incorporate it into their practice. Because it doesn't take anything from them. It improves their practice, and it helps improve the outcomes that I believe they all want to get with their patients and in their communities. So I think it could definitely be taken up by the workforce, and otherwise, support the goals that PIBA has for this.
I want to quickly respond to the second around educating the Black community on PrEP. I think this study will showcase elements of how to do that and what areas are barriers and challenges. Because I bet if I did a poll of the people on the webinar and my fellow presenters, even working in this field on a daily basis, we have still had friends in our social circles who has received an HIV diagnosis in our tenure in this work. And even though PrEP was available. And so it's a lot of these nuances that we have to think about: education, interventions, how we communicate, how we showcase clear communication in this work and delivery around PrEP messaging. I want to pivot over to the third one around supporting a federally funded national PrEP program. The federal government, and this is me speaking from my previous federal government career experience, I would say failed in the majority part regarding PrEP programs writ large. When we think about what has been, a donation of appeal without elements of, things around social determinants of health, cost factors, copay factors, none of what has been done thus far in the HIV response around PrEP has worked. And so the impetus is really thinking about how do we go and do our due diligence and letting community lead this piece. And I think in order for it to be successful, we also have to take in consideration the recent data that was already talked about in this webinar. The lowest numbers are Black communities who are actually prescribed and sustained on PrEP in America. And so again, knowing the data, the epi, and knowing that the federal leadership and even partnership with companies has not necessarily been successful, going to community and allowing them to be the voice, the lead, the making the table and putting the chairs at that table is going to be how we see something that could be potentially successful, because what's been done has not worked. Thank you.
And then very quickly, when I look at those 3 points, I think the two that I would very quickly speak to are both recommendation 1 and recommendation 2, right? Recommendation 2 speaks to educating the masses, sort of the Black masses, about the science and effectiveness or efficacy of PrEP. I think that's really important because I know I still come in contact with people, both men and women, some of whom will say with regard to PrEP, oh, well, that's for the gay people, right? Like I'm a cisgender woman. This isn't for me. I don't see myself, represented in any of the commercials and any of the ads, whatever. Like we may not. There are even studies that have excluded different populations, right? And so if however you identify was not a population that was included in the trial, not only does that raise concerns about generalizability, but even how you might understand and think about it, and even how providers and other researchers might think about whose a product is or isn't available for. So I think there's that component, but I don't want us to walk away feeling like the burden is on our clients or our community members to educate their providers when they walk into a space. I really do feel like the requirement about, or the need to energize the workforce, and not just the Black workforce, but to provide this information to the entire workforce of health professionals, so that not only do they understand about their own sort of biases and how stigmatizing language comes out of their mouths and what the impact of that is, but also to look at some of the systemic impacts of those types of things in their work and in their clinical practice. Are there questions that might be a part of their assessments that really aren't culturally attuned to the needs of the people or the populations that they're serving? Those are some of the sorts of things that I think are critical points that can also be used to impact uptake of some of these services and awareness of the need and benefit of PrEP and other linkage to care type of resources. So yeah, thank you.
Great. Thank you, Christopher, for that feedback. And so, you raised some really, interesting points, right? We know that, with the recent Supreme Court case shooting down affirmative action, for instance, that there are going to be some challenges presented to us, right, as it relates to sort of educating and leveraging the Black public health workforce, right? Training, new doctors who are Black and other folks of color, because we know that, when people are treated by folks who look like them medically, they tend to have better outcomes, right? And so we're definitely going to have some challenges in that regard. And then in terms of the other recommendation from PrEP and Black America around sort of educating the community about PrEP and current available, PrEP modalities and other interventions. We also know that there are things coming down the line, right? Hopefully one day we'll see, a vaccine or for HIV, or technologies or therapeutics that leverage, broadly neutralizing antibodies, right, for prevention and treatment. Maybe one day a cure, right? So we want to sort of get ahead of, those things by a lot of the foundational work that 096 is doing right now as it relates to sort of, addressing these social and structural level, multiple level factors for health outcomes in HIV among Black gay men in the South. And so, hopefully one day we'll be able to say, we can look back on 096 and say, we were able to make sure that a cure and a vaccine got to people because we realized with 096 that X, Y, and Z needed to happen, right? These things need to be in place. Thank you all for your contributions towards this work. Thank you all for joining us today on this webinar. Definitely look forward to more coming out from the study, more coming out from this intersectional stigma measure that will one day see the light of the day. And I'm going to pass it over to Jim, who will close us out with any sort of logistics for the webinar and other announcements.
Perfect. Thank you, Riko and John, for moderating this really wonderful discussion. Thanks to everyone who came. A huge thanks and appreciation to our 4 speakers and presenters, LaRon, Cedric, Christopher, and Abraham. What a great array, and really telling such a rich and fabulous and interesting story and inspiring story about the kind of work that actually has to happen to make this stuff come alive. So thank you for that. We will be sending out a reminder email soon in the next couple of days that'll let you know when slides, recording, and resource document is posted on the Choice Agenda page on AVAC's website. And I look forward to seeing folks at our webinar series in the new year. We already have January, February, March, and April booked. We're going to be talking about journalist trainings, training media and journalist folks around HIV issues in Africa. We have another discussion on decolonization to follow up on our one from earlier this year. We have a whole webinar devoted to the new Adolescent Trials Network and the really incredible work that they're looking to undertake over the next 7 years. And we will have a very interesting discussion on how best to measure and evaluate PrEP uptake and PrEP use in various countries around the world. That's just a taste of what's coming. Many more things to come. I hope to see you there. But in the meantime, thanks for showing up. Thanks for hanging out with us for the whole time. For those of you who registered and didn't join us live, I hope you have enjoyed this recording. You are at the end of the recording now, and I'm going to officially close out this webinar by again thanking you all for your participation. Once again, thanks to our partners, PrEP in Black America and the Research Working Group of the Federal AIDS Policy Partnership. And whatever time it is, enjoy the rest of your day and enjoy tomorrow and the coming weekend. Take good care. Bye-bye.
Bye-bye, everyone. Thank you.
Bye-bye.